Hi, welcome to Two Guys in Scrubs. We are Two Guys in Scrubs. I'm Silas Rades.
And I'm Delbert Yip. We're second-year medical students at the University of British Columbia, and we started this podcast to share what it's like going through medical school, discuss medicine, and pretty much anything else.
Please be advised that Two Guys in Scrubs is for educational and entertainment purposes only, and the views expressed do not reflect the views of our program or supervisors.
So Silas, it's been a while since we last talked. Just to update our listeners, we have just completed our second year of medical school, and we're currently in our Flex research block. Silas, how have you been doing?
I've been doing well. It was a big push for me to finish the end of the year, and I guess we're pretty much finished. We haven't got our results of our clinical examination yet, which is everyone's kind of waiting with bated breath. But it was really nice to finish. Felt like a bit of a milestone. It was a good push to finish the year, and I'm feeling quite good. I'm feeling great. I'm enjoying to have a month off and be super free. And by free, I mean just do research all the time.
Yeah.
How are you doing?
Well, personally, I enjoy being at home. As you know, I'm a bit of a homebody. That might be under what's it called? The opposite of hyperbole, whatever the word is. But
hyperbole,
anyway,
of course.
Hyperbole, yes. But yeah, I've enjoyed time at home. One thing that I actually mentioned to you before the podcast is perhaps a negative effect of me spending too much time at home is decompensation. So yesterday when I was going out for a walk just to the pharmacy, which is about maybe a 10-15 minute walk from my house, picked up some medication there, and then I walked back, and then after I got back home, my tibialis anterior was sore bilaterally. So that's how I know it's like, oh man, I'm exercising at home, doing like squats and push-ups and stuff, but I probably need to do a little bit more like, I don't know, endurance.
You're on Family Med and someone like young, fit 20-something-year-old comes in and gives you this history. Is deconditioning going to be on your differential?
Yeah,
probably not. You'd miss it.
That's when you need to do the social history. It's like, oh, have you been spending like 10 hours a day at home, sitting at the desk, writing your Flex review?
Oh my God. Well, I'd like to hear more about, especially your experience doing your clinical exam, or OSCE, as it's so called, the OSCE.
Mm-hmm.
Now I even forget how it's spelled, but I not on today's episode, maybe on next episode, because today we have another very amazing guest, and we're super, super happy to be able to bring it to you guys. And our guest this episode is Dr. Larry Chapman, who's a Vancouver-based hospitalist and clinical lecturer, whose path in medicine was shaped early on by his grandfather, a physician who modeled empathy, connection, and dedication to the person behind the illness. He completed his medical degree at the University of Cape Town, graduating with first-class honors and distinctions across all phases of training, along with awards in internal and clinical medicine. During medical school, he also founded the International Association of Student Surgical Societies, reflecting an early commitment to leadership and collaboration. He went on to complete his internship and community service in South Africa, followed by a diploma in emergency medicine, working in high-acuity emergency settings, where he managed a broad spectrum of complex medical, surgical, and trauma patients. After relocating to Canada in 2017, Dr. Chapman spent 5 years in a peri-urban and rural Alberta setting, working as a hospitalist, serving as chief of emergency, and continuing ER practice. His work in a resource-limited environment, caring for high-complexity patients, significantly shaped his clinical approach. During that time, he also pursued oncology training at the Cross Cancer Institute, practiced community GP oncology, contributed to medical education as an assistant clinical professor, and completed certification in point-of-care ultrasound. Since moving to Vancouver in 2022, he has been a full-time hospitalist at Surrey Memorial Hospital and a clinical lecturer at UBC. With ongoing interest in teaching, quality improvement, and navigating medical complexity, an absolutely fascinating and impressive bio, and without any further ado, we bring you Dr. Larry Chapman. So, hi, Dr. Larry Chapman. It's great to have you on the podcast. Our listeners just heard all of your illustrious bio, so they already know everything about you. But how are you doing today?
I'm doing great. Thank you so much for having me on your podcast. It's you guys are doing a fantastic job, and just really excited to join you today, and also take the opportunity to wish you a happy Physicians Day. As physicians in training, it's officially Physicians Day. So appreciate you guys, and keep doing the amazing work that you're already doing.
Thank you.
I had no idea that was a thing.
Yeah,
That's a real
same.
thing, hey? Our
It
program doesn't stress it.
Don't
But yeah, no,
expect
really.
any free coffee or
oh
baked goods, but
Well, no, certainly the pleasure is all ours, and we're really excited to get into a range of topics with you. But just let's start at the ground floor, asking about your current line of work, which not every one of our listeners might be familiar with. So I want to start by just asking Larry or Dr. Chapman, what is a hospitalist?
well, it's an interesting question, given that I didn't know what a hospitalist was when I left South Africa and moved to Canada. And what's also interesting is that when you tell a patient that you're a hospitalist, often they hear that you're in the hospitality industry or you're from hospice, which can be alarming to certain patients. So sometimes we call ourselves hospital physicians or the family doctor or whatever comes out the mouth in the moment. But basically, a hospitalist is usually a family physician, but we do also have internists as part of our group. And basically, it's a a blend between general medicine, family medicine, in a hospital setting, looking after the vast majority of admitted patients with every diagnosis under the sun that doesn't require a monitor. And yeah, it's also kind of nuanced in the setting in which you work. Certainly in rural settings or in certain hospitals where a hospitalist is the default admission physician. They'd be basically taking on the majority of the admitted patients. But in certain teaching hospitals, internal medicine would do that, especially where there's a CTU. So yeah, general medicine, looking after sick patients. Yeah, that's about it.
Wonderful. And yeah, as we know, you're currently working at Surrey Memorial Hospital in the Lower Mainland here in British Columbia. And we're not very familiar, but I imagine that every hospital runs its hospitalist service a little bit differently. Could you speak just a little bit to how Surrey chooses to run their service and any differences or comparisons between the other hospitals that you know of? Maybe what you love and or maybe what you wish you had, etc.
Absolutely. So to kind of paint a picture of how much I love working at Surrey or SMH or whatever you want to call it, I live about 4 minutes drive away from VGH, and I drive all the way to Surrey just to work at the hospital there. And each hospital is service and each hospital is unique. But what's so amazing about working at Surrey is that the hospitalist footprint is huge, and the flow of patients from the emergency department to admitted beds is usually to us, and we have the opportunity to look after anywhere between 350 to 400 patients per day. There's about 24, 25 of us working during a day shift, and those numbers obviously decrease to much less for the evenings and the night coverage. But it's just a fantastic team of over 100 hospitalists, all different backgrounds, Canadian trained, US trained, family medicine, internal medicine, plenty of IMGs, and it's just a wonderful working environment with incredibly talented, dedicated physicians. And it's such a fantastic supported ethos. We've got medical students, residents, so there's obviously quite a big influence on teaching, and such a wonderful working relationship with our specialist or consultant colleagues. And it very much is a shared care type of setup. And we really see such an amazing selection of pathology with a massively expanding population, many immigrants coming from all over the world, it's just such great pathology. It keeps you on your toes, working hard. I know that, there's obviously what's discussed in the media and between different hospitals. Often Surrey is painted as a very busy hospital, which it absolutely is. It's the busiest emergency department, or one of the busiest emergency departments in the country. And just I feel like the majority of people who choose to work there are so dedicated to delivering amazing care under a situation or circumstances where there's just such a strain on numbers of beds, of resources, but everyone just puts their head down and they work together, uplift one another, working hard, and ultimately it's very much patient centered and focused care, which is something that I am incredibly passionate about. But I find that especially coming from South Africa and a similar type of environment, I haven't worked at all of the hospitals, so I can't comment about the what it's like to work at every single hospital, but I feel like the mix is just so amazing at Surrey. And again, kind of going back to part of your question with regards to what it's like, the structure of the hospitalist services at other hospitals, there's kind of a general backbone how hospitalists work, doing the admissions, caring for the patient while they're admitted, and then hopefully discharging them out of the hospital. But it really kind of stretches such a huge breadth of potential pathology, because it's not just medical patients you care for. It's we consult on surgical patients, general surgery, gynae, orthopedics, ENT, thoracics. We the MRP for all the stroke patients, neurology, many of the kind of shared cardiology patients who don't actually need to be under the cardiology service. We manage non-operative surgical patients as well, step down from ICU, many patients on dialysis, multi-organ failure, basic, almost everything. And it's just a fantastic opportunity to kind of really, help as many human beings as possible, but also learn something new, at least one new thing every single day.
Wow, that was a very extensive response and very detailed. I personally have not spent much time in Surrey, and I don't know if I have a rotation there myself. I wanted to ask about, you mentioned having a very high throughput of patients as well as this wide diversity of pathology, which must be challenging. How do you balance this? How do you kind of just sustain yourself in this very challenging environment?
It's a very good question, and I don't think I'm perfect at it. But when I reflect on this quite frequently, there's this kind of constant balance when working in a busy environment of how do I get through the numbers, but also how do I stay true to who I am as a human being, but also who I am and want to be as a physician. And those two things are often competing because in order to get through numbers, you have to have a certain efficiency and speed, but also sometimes one patient can take you 2 hours where another patient can take you 25 minutes or even less than that. So it's this kind of balance of how do I show up for my patients, and how do I stay true to what I believe in. And I think throughout one's career, there's this kind of flux where one can be in an environment where it's really easy to just kind of churn through a huge number of patients, but other times where you can be on a very complex medical ward where that's just not possible. So it's not a perfect balance, but I think for the most part, and something that I believe in is, staying true to who I am and who I know I want to be for my patients, and having a set standard and being kind of uncompromising with that standard. And then just to kind of build on that a little bit more is that sometimes we can feel like we're in silos, especially in a very large hospital. But ultimately, it is such a shared experience, and we are heavily reliant upon, obviously, ourselves, but everyone who forms part of the patient's care plan and care team. And that stretches from everyone from the housekeeper to the nursing staff to all of the consultants who are helping out with this patient. But obviously, me or my colleagues taking on the responsibility of being the most responsible physician. And sometimes when it's so busy and there's so many things kind of coming at you at once, and you're multitasking and you're pulled in so many different directions, having methods to kind of keep oneself grounded and focused and calm and able to kind of think through things in a logical manner, and realizing that you're one person but within a team. And I think acknowledging other people's roles in the service of a patient and the care of a patient is incredibly important, but also kind of leaning on one's colleagues in that team, or even bringing on other people from the team, and checking in with one another, supporting one another. And I feel like that is such an important part of kind of general care and surviving the days and thriving in a hospital setting that's so busy. And obviously we can talk about balance outside of work, and staying hydrated and eating and resting and things, but that's the kind of ideal. But kind of in reality, it's so multifactorial, and you'll hear that word, I'm sure, many times on this discussion, and you'll hear it throughout your medical training, and then you'll start using it more and more as you start becoming attendings. But it's true, it really is multifactorial.
Very inspiring. Sorry, Sas, go ahead.
I was just going to say, they all sound like great things, drinking and staying hydrated and sleeping, but Delbert could use a little bit of education on moving, which he doesn't tend to do very much. And
yeah, I was just telling Silas before this that I had a walk yesterday, and I came back home and my tibialis anterior was sore.
But no, it's really interesting to hear kind of some of the more internal processes about dealing with how demanding your job is. But I want to take a step back to your earlier career, because we know you've had such a diverse career, doing training in South Africa and then moving on to running emergency departments in South Africa, which, as you've said, as we learned in your bio, that running an emergency department in South Africa is different than running an emergency department in Canada. It's going to be higher acuity. You're probably going to be doing more surgical operations in the emergency department, etc. So
sorry, that was in Alberta that I was running the emergency department there, but I worked as a senior house officer in South Africa.
My apologies. You did a senior house officer in South Africa and running the ER in Alberta. So you've been able to experience both. But maybe I'd be curious to know how you were able to transition your skills and like what you learned working in emergency in South Africa, and then coming to Canada and eventually becoming a hospitalist. How do you think that you're able to transfer some of those skills? What stayed, and what new things you had to learn, or what valuable skills did you develop working in such a high acuity setting, moving into a slightly lower acuity setting, working on your hospitalist job?
I think it's a brilliant question and multifactorial answer. Okay. So let me kind of paint a picture as to what it's like in South Africa, what it's like here, and kind of how these things kind of marry together and how they're different, etc. So in South Africa, there's a two-tiered system. There's a public system, a private system. Everyone trains in the public system. Public system is overburdened, and basically everyone who's got medical insurance or money would access the private sector. And all of our training is done obviously in the public sector, and I can tell you that as a young, impressionable, highly motivated, junior doctor, I had such amazing mentors working in South Africa in the emergency department. And I don't know if you'll ever listen to this podcast, and I'm sure in the moment he didn't even realize how influential he was. But Dr. David Fredericks was. I was working in. I can just kind of picture the scene working in the emergency department in South Africa. All the stories are true, by the way, that you hear about and you see about. It is so busy. This is obviously in the public sector. Just you start a shift. There's 50 people waiting to be seen. There's 5 intubated, ventilated patients in the trauma bay. There's no ICU beds. There's like 3 nurses on shift. You're putting in IVs and central lines and taking blood and throwing X-rays up onto a board before we had the PAC system. And it's the month-end weekend, and everyone has decided to spend all or part of their paycheck on booze, and now they're stabbing and shooting one another. And then the burden of HIV and TB, and there's just people kind of walking around the emergency department, just like lying on the floor. It's all true. It actually does happen in reality. And
unbelievable.
Yeah.
Go on. I just had to butt in there because you're painting such a vivid picture. It's unreal.
Yeah, but that's the normal, and you train in this environment, and you just cannot believe that the amazing level of care that can be offered to patients even under those circumstances. And it's certainly different in terms of what the level of care that someone would expect, just say if they were in the private sector, or if they were in a first world country. But and certainly if you can walk, then you're probably going to be discharged by an admitting service. But it really gives you perspective. And what was so interesting, and when you're kind of living through it, it's certainly challenging. But to work at some of the referring sites, and then also work at the site where I would then kind of send on to a tertiary level hospital for, just say, neurosurgical intervention or vascular surgery or whatever it was. But to understand who was sending the patients to me, what they had in terms of resources, or most likely what they didn't have, the setting in which they were working, and the fact that they probably couldn't even get an X-ray, or the quality of the ECG was, they had to use those little, I don't know if you guys have ever even seen these kind of metal suction cups that you have to place on a patient and use gel, and you can't even believe what people do, and they still were able to save a life and then send it on. It gives you so much perspective about what a physician is going through when they send a patient to you, and how you are the next step of helping out, and also kind of understanding the perspective of all of the patients they didn't send you, and they actually dealt with. So and the reason why I bring this up is because whatever you guys choose to be when you grow up, and also many of the listeners, is that understanding the perspective of where your patients come from, how they refer to you, and also having the perspective of receiving and then sending on patients, is that you'll hear a lot of people complain. And, I can't believe that they didn't think of, this subtype of vasculitis, or, how could they send me this simple patient and their interpretation of the ECG was wrong, or whatever it was, or the CT brain was actually normal. The patient doesn't have a bleed, and they actually have conversion syndrome, whatever it is. And often those types of things come out when people are burnt out and frustrated, etc. But, I'd say that if you guys are wanting advice about really kind of becoming wholesome, well-experienced physicians is understanding that process. And then I would also add, kind of back to the experience in the emergency department, is that the skills that you have to pick up when you're in an environment out of necessity because patients' lives depend on it is an amazing environment in retrospect to really kind of push yourself in terms of your knowledge and skills, and you'd be amazed by how much you can actually do, but also amazed about and staying humble about all the things that you don't know how to do and you might not know. And that's when you ask for help, and or when you look it up yourself or you figure it out. But that's when the learning really happens. You have an amazing opportunity to be in medical school and learn the textbooks and acquire all of this knowledge. You've kind of knowledge collectors, experience collectors, and kind of figuring out, how does this actually integrate into how I see patients? How do I care for patients? How does this actually realistically pan out in life? But it's all relevant, and again, you'd be amazed as to how you use that in your practice. So, kind of back to the emergency department in South Africa. Just having an inspirational leader, mentor who cared for patients of the highest quality, led by example, made things fun and humorous in a very stressful and kind of dark time. We had a great team. We would do a weekend of nights, and then on the Monday morning we'd all go out for breakfast, and we would take 5 minutes on a shift and have a quick coffee together. Those small things of kind of getting through a really tough situation, and kind of really being dedicated to offering the highest quality care to the patients. And I think that was the environment in which we were training, is that one was rewarded kind of socially and intellectually and in whatever other realm one wants to think about, was that accomplishment came from dedication and the highest quality care of patients. That's what mattered most to everyone. And certainly no system is perfect, and I'd say that there's probably a much higher rate of burnout. But I think training in that type of environment is incredibly important, and kind of shifting one's mindset to understanding that we're in a very unique service industry where we have this opportunity to care for patients often kind of at the lowest points of their lives, when they're very vulnerable. And we have this opportunity to actually positively impact not only their lives, their families' lives, a community, etc. And being in such a stressful environment can really teach you how you can still offer that no matter what the circumstances.
It's fascinating and such a rich discussion that you were bringing. So many points that we could further discuss. I think two things jump out to me. First, it's interesting what you said about silos and the value of having experience within so many different facets of medicine or within the hospital, just to be able to have that perspective of when you receive a patient or when you refer a patient, to understand a little bit how the other service might work, because otherwise we're left just making total assumptions about what the other services are doing. And like you mentioned, you get an ECG and the cardiologist upstairs like, oh, what are these ER docs? They must read these things blindfolded or whatever it is. But when you don't have that lived experience working on the other services, then it's kind of left up to the imagination. But I did have one actually more pointed question, which was, you've described this experience, you've worked in South Africa, you've worked in more rural parts of Canada. I imagine some of these environments you can work where the medicine is a little bit more, I don't know what to say, guerrilla, rugged, less red tape, less bureaucratic processes, et cetera. And I'd be interested to hear the comparison. Is there anything about having a more guerrilla type system that can maybe even get things done more efficiently. Or likewise, it's clearly having more resources like an urban hospital like Surrey clearly has a lot of advantages compared to working in a more underserviced or more underserviced area. But if you could compare and contrast just on a level of resources and level of process and policy and procedure between the two environments, and I'd be interested to know if some of the more rural or South African style medicine might be able to have some advantages compared to our highly process oriented urban hospitals here. If that makes any sense. Obviously, other medicine's still process oriented, but in terms of more the administrative or bureaucratic side, etc.
It's a great question. I don't know if I have a perfect answer, but I'd say, just kind of reflecting as you were asking the question about South Africa, and then also working in a peri-urban city in Alberta. I'll first start off by saying that I was very naive. I thought I knew what Canada was going to be like, and I was, coming here thinking that it was going to be a, beautiful white cloud of goodness with a beautiful silver lining, where there were just untold resources, and it was, in hindsight, completely ridiculous. But I'd say that being in a rural setting and kind of learning the ropes in Alberta, it actually took, I'd say, at least 6 months of working in the system to actually really kind of understand it. And certainly there's a lot of differences between how Alberta and BC kind of operate, not only from kind of the EMRs and medical information sharing, but I'd say that there's very much a kind of top-down approach in Alberta, and kind of Silas, what you were talking about, very kind of organized and very set process. And so I think that there's kind of pros and cons. So in South Africa, when you're kind of doing this kind of bush type medicine, but it's not really in the bush, you're in a beautiful city of 6 million people that's highly developed and amazing, but under-resourced in the public sector. I think in the moment, the kind of band-aid medicine of you can actually get a lot of stuff done in an efficient way with limited resources. It's absolutely 100% possible, but I think in the short term it really helps, but in the long term, it's a partly a broken system, and starting someone on HIV and TB meds and then discharging them from the emergency department just because they can walk is that would never be tolerated in a Canadian hospital. I mean, that's or even in a private hospital in South Africa. So I'd say amazing that someone made the diagnosis of just say HIV and TB, which is just incredibly common and tragic in South Africa. But then what's the follow up? They just get given their first few doses of medications, and they're given a 3-line letter to go to their what they call the day hospital, which is basically like a overpopulated strained clinic, to go see a doctor there, and just kind of accept it. It's it's really not great from a longevity perspective or kind of continued care. But certainly in the moment, and kind of when it comes to the trauma and other kind of minor things, of course you can kind of get through very high volumes and still kind of help people in general. I'd say the experience in rural Alberta, or kind of peri-urban Alberta, was amazing. I was there for 5 years, and certainly an opportunity to see very different style of emergency medicine, because I was doing, as you know, a kind of hospitalist, and then doing shifts in the emergency department, and then took on a leadership role for the emergency department, and that was kind of leading up into COVID, and that was crazy. Kind of trying to navigate this unknown and the kind of infectious diseases protocols and or I guess infection prevention and control protocols, and kind of navigating that as kind of newly emigrated to Canada and trying to figure out the system and what the expectations were. But I had received excellent advice from the couple who had recruited me to the town in Alberta. And I could probably have a completely different podcast about the process of an international medical graduate coming to this country. That was unbelievable. But they had advised me to go and do some shifts in the private sector in South Africa, which I did. And it was some of the best advice that I actually ever received in the process of moving. To really kind of understand what the clientele would be like, what patients' expectations would be like, working in a slightly, better resourced situation, documentation-wise, access to technology and resources, etc. So there was a lot of similarities in that regard. But I, really kind of moving here and starting to practice medicine really kind of opened my eyes as to what the opportunities could be like for patients and what the care actually could be, and the longevity of the patient and doctor relationship, and kind of how many resources there are from a really multidisciplinary and biopsychosocial, spiritual support level for patients when you make the diagnoses, when you care for them in the hospital, and then when they eventually leave your care and continue in the community. So lots to kind of talk about and unpack. But yeah, again, kind of summarizing, it's about experience, learning, connection, and kind of taking all of these past experiences and kind of building them and shaping one's perspective and outlook on how to care for the patients in the now.
Wow. You've clearly had a lot of experience working in different settings. I mean, we've talked about working in under-resourced areas as well as overstrained areas. And we've mentioned how we can sort of adapt to these at the physician level or at the team level. But I was also interested in hearing your perspective on how we can address some of these issues at the system level. And specifically, since you mentioned COVID, whether you noticed any difference before and after COVID. Basically, what actually helps moves things forward when it comes to systemic change in healthcare?
So I think I would kind of think about this on different levels. There's, on the ground level where you have a patient and a physician and then a team also looking after them of allied health. And then there's, the patient in the community, and then kind of going up the chain all the way to the top of, health authorities, etc. And there are just so many factors at play when it comes to the care of a patient and the minor details that mean so much in their care. And I think kind of leveraging one another in the team to kind of really move things along in an efficient way is incredibly important. But I think there's so many facets to this. Having a patient understand, number one, what's actually going on with them. What's the diagnosis? What does this mean for them? Why are they even in the hospital? What are we actually doing for them? And then really, uplifting the immediate team around you to deliver the kind of the plan of care for the patient is just so incredibly important. So to kind of move things along, you obviously as a physician, whether it's before COVID, during COVID, after COVID, whenever it is, need to be kind of very clear with what the plan is going to be for the hospitalization and what the plan is going to be going forward. But how do we actually use one another in a positive way to execute that plan? So uplifting one another is I want to just talk about this a little bit more because I think it's so important in this kind of team structure. But really learning from one another, educating in a kind of non-judgmental way, not kind of criticizing mistakes, because we all make mistakes and learn from it, but really being advocates for our patients and being open, honest, communicating, and telling a patient that you've got their back and you're actually there to help them, and bringing the family on very early, and kind of discussing what is actually realistic for, talking about what home is going to be like after discharge, how can we best support a person, and kind of relying on, just say, the health authority to deliver home care services. What can the physiotherapist and occupational therapists bring on from an equipment and a mobility perspective? The social workers who are, trying to improve so many aspects of the patient and the family's life, and kind of really understanding the impact that this person's hospitalization and diagnosis, and maybe they have new deficits or new care needs, and kind of how that is going to impact a family unit and a community. One has to really kind of appreciate all of these nuances to kind of understand how to move the system along. And in terms of efficiencies, there certainly is a lot of duplication of work and services and investigations. And I think people just need to take an extra 5 minutes to, for example, in our health authority, we have an EMR that's pretty kind of outdated, using Meditech and a kind of blend between Meditech and a paper chart, and then hopping onto UCI or Care Connect to see some of the community investigations or some of the labs that don't show up on Meditech, or some of the things that happen in the other health authorities, or they went to VGH for whatever. Really kind of looking at what has been done and what is the reason that the patient is here, and how do I use resources in an appropriate manner, and being judicious with how we order these things. Is all of these things are so important in trying to move things along, but in the most efficient way. And also speaking about how to be an adequate patient advocate is going to the higher ups at times and signaling that we actually do have a problem, and how do we work together to fix it, coming up with solutions, empowering quality improvement, training the next group of doctors who are coming through to have these types of mindsets. All of these things are so important, and I'm probably leaving out a huge number of important elements to this, but it really, one has to rely on other people and rely on oneself to kind of really move things along and try to be efficient in a system that's not always designed to be that efficient.
Yeah, so interesting. And I think along that line, I'd like just to share about one of my recent experiences this year, and then I'd like to hear your reflections. And it's within the realm of quality improvement and systemic efficiency, and especially when it comes to the EMR. So yeah, as second-year medical students, we have to spend some amount of time with a family doctor who has a niche or a focus or a plus one. This semester, mine was with a family doctor who's a hospitalist, and I worked with him at VGH. It was very interesting, so I got to experience what it's like to be on the hospital service. And one thing he tasked me with, he said, here's kind of a complex patient, here's the EMR, study this patient for the next 20 minutes, and because they've been here for a week, and you have access to all their information, and then I want you to present to me what you think is going on and what are next steps that would really serve this patient. And I kind of, as I went through this exercise of trying to collect all the relevant data from the EMR and kind of synthesize it into a coherent narrative or summary in my own head, I was kind of looking at the EMR and then jotting things down on paper. What I noticed, at least from my perspective, was the patient data can be quite rich, especially in these urban hospitals and in 2026. Rich but disperse, where if a patient's been in the hospital for a week, at VGH, there's so much information that's been collected on this patient, but nowhere really in the EMR can I go and just see a good summary or integration of this information in a nice dashboard, for example, and kind of get a good glimpse at the patient trajectory. Because I imagine as a hospitalist, especially as you're switching services, okay, now I have, when you would take over a patient that's being looked after for the previous week by a different staff, by a different physician, your first step is okay, I need to wrap my head around what has been this patient's course over the last week. And just what I noticed was that the information can seem so disparate. I have this in this section, this in this section. I'm having all these tabs open. I'm trying to integrate it. And from a QI perspective, I just found myself thinking, wow, if someone could design an EMR where I can log in as a hospitalist and kind of visualize all the information in one to get a good understanding of what this last week has been like, that would be so valuable. I feel like this would speed up this process so much that I just spent half an hour digging through their charts. So that's my own reflection. And I'd be interested to hear from someone who is actually a hospitalist, from your perspective, kind of what is in your day-to-day, maybe interacting with the EMR at Surrey. What are some things that you think wow, if I could have a magic wand and make this happen, this would make my job so much, easier, more efficient, more effective, et cetera. I'd love to hear some of your thoughts on that.
This is a brilliant reflection. Absolutely brilliant, and kind of speaks to something that I am very passionate about. So at Surrey and I think many of the other hospitals, we have a set rubric of what needs to go into a transfer note at the end of a week, because Mondays are horrific. Horrific in the way that, as you described, you coming onto a new service, the vast majority of these patients you've never seen before, and you're really trying to kind of understand what's going on. There's so many different data points. Some of them are written, some of them are only in the EMR, some of them, it can be tough. And I think, number one, it comes certainly with time and experience of how to identify what is useful data and what is not. And kind of creating the summary, I must say that AI has been very useful in cutting down a huge amount of time when it comes to this. And, with the new AI scribes, you can just upload data into the AI scribes, and you can tell it how you want it to summarize. And I've been using Heidi AI scribe for quite some time now, and it really does help integrate a lot of this information. But I think it really does come down to you just need, from the beginning, as the patient kind of goes through their complex hospital stay, you really have to take it upon yourself to not only pay it forward for yourself, but for the next physician who comes on. And obviously, it positively impacts patient care. But to really keep an kind of ongoing daily summary of how things are going, what has been done, and what the plan is going forward. And one of the techniques that we have is that and basically this kind of rubric or guide is in the structure of basically what a discharge summary is eventually going to look like, which is very similar to a transfer summary, and kind of broken down into the most responsible diagnosis, the pre-admission diagnoses, the post-admission diagnoses, the secondary diagnoses, allergies, code status, consultants, and the kind of main investigations, and any interventions or surgeries, etc. But the meat of it is the course in hospital. or the kind of treatment, what the plan is going forward. Everyone needs to have a plan, and it is incredibly important that that is very clear. So something that has worked for me, and I know many of my colleagues as well, and I'm always finding ways to be more efficient, and it's not perfect. And there are plenty of doctors who are way more efficient than I am. And I think this kind of trying to find this balance of being thorough and at the same time, building, useful notes is that just say if the patient has pneumonia, hypoxic respiratory failure, an acute kidney injury that's pre-renal, and they had a type 2 myocardial infarction. You separate those headings, and step by step have the same process. You take the opportunity under the heading of just say pneumonia and hypoxic respiratory failure, and you say the patient presented with this, the X-ray showed this, the CT showed this, respirology was consulted, and they suggested that the patient needed a bronchoscopy because they were concerned about X, Y, and Z. The cultures showed X. The patient started antibiotics on this date. The plan is that, they're on Optiflow now. We're weaning it to nasal prong oxygen. The respiratory therapists are following up. The patient has a follow-up at the COPD clinic because they actually have COPD. And the pulmonary embolism was excluded, and the antibiotics are going to be stepped down to oral, and this is the stop date. Nephrology was involved with their renal failure. They didn't need dialysis. They were given fluids. They got better. The infection was treated. This is what the urinalysis showed, etc. So kind of the most useful data points that if you had to picture picking up that chart in the middle of the night when, just say, a patient has deteriorated, and you or a colleague could pick up that chart and in 2 minutes flat, you could know exactly what the meat of the case is, but you were diligent in keeping that up to date, I think is the answer. And as you've identified, there's a lot of note bloat and a lot of unnecessary stuff that finds its way into an EMR, and it really is kind of our responsibility to declutter or debride the chart, as people sometimes talk about. Yeah, that's how I would approach things.
I also have similar experience as Silas. I've been doing some research in oncology, and sometimes I'm digging through these notes, just looking for what actually happened in their last stay. So it can be quite difficult, especially with very long visits, as you say. I kind of want to get into your experience in ultrasound, because we've had a bit of exposure through our coursework and our clinical skills sessions. And heading into clerkship, I think both Silas and I are really interested in learning how to just do POCUS a little better. How would you recommend gaining experience with POCUS as like a medical student?
I think it's fantastic that you guys are looking at POCUS and wanting to use ultrasound. It is practice changing technology that's obviously been around for a long time. So quickly about my experience, I'd first started interacting with it mainly in the emergency department in South Africa, and had done some minor training courses, and I was just taught by from a mentor perspective, and started kind of picking up on a few things, and again, collecting knowledge, a little bit of experience, trying to get a really good image, and how can this actually change? It's all very well getting a nice image, but how does this actually going to help me and help the patient? Because I think this is a kind of important point to get across, and I'll use kind of ultrasound to leverage this, is that we taught in medical school about from the textbooks and from lecturers, etc., that there's all of this information that you collect. These are the clinical signs that you would look for, but ultimately it's not perfect. It gets you to the point where you can suspect that there's a diagnosis, but it really is helpful to see it with your own eyes. And it's not only helpful for you, but it's also really helpful for the patient. If you kind of take a step back and picture yourself as a patient or a family member, whether you're in the emergency department or in a hospitalist ward or in ophthalmology or interventional radiology, whatever it is, you have this very easy tool to put on a patient where you can see exactly, what is happening. You can show the patient, which is super cool. And patients really like it. They really like it. And instead of doing things from a procedural perspective as well, doing things blind, you can do it under ultrasound guidance. It just makes complete sense. So I'd say that getting comfortable with it's just like small things. Where do you put your body when you're ultrasounding someone? Where do you sit on their bed? Do you stand next to them? Where do you put the screen? And figuring out how to turn on a machine is really important. Some of the older machines, it can take some time to really understand how to turn on a machine. You look like a bit of a fool in front of a patient when you don't even know how to turn on a machine. But it's just those small things. And then, starting to understand, why am I doing this cool thing? What is this going to show me? Is it actually going to be able to confirm a diagnosis? 100%, especially in the emergency department. It is so useful. You can look at their heart. You can look at the lungs. You can diagnose an effusion within seconds. You can look at their lung sliding. You can diagnose a pneumothorax with way better than trying to get an X-ray. You can put lines and tubes in people. It's absolutely fantastic. So certainly from an emergency medicine perspective, it was super useful. So did a course in South Africa, and then when I first moved to Alberta, I'd say maybe for the first 6 months or so, ultrasound wasn't as kind of important in what I was kind of figuring out where I was going to be and what I was going to do. And then I kind of rekindled that love for ultrasound and kind of wanting to be a better physician and for my patients. And then I started hearing about the C-POCUS that's offered here and started looking into that. And I was, and still do really enjoy listening to emergency medicine podcasts, and I'm obsessed with ECGs and, that kind of love for learning and especially kind of new tools and cool things to use in the emergency department kind of, really accelerated. And then started looking into, well, if I want to do ultrasound in the emergency department, maybe my colleagues would also want to do ultrasound in the emergency department. So I started looking at how do we host a C-POCUS training session in the city that I was working in. And then we landed up organizing that, and the majority of the emergency physicians and the hospitalists in this smaller site all did the training. They all passed the exam. It was a huge undertaking to organize, getting all of the volunteers, etc., but we were able to do it, and it really shaped the way that medicine was practiced. And the board of the hospital even paid for a very, very beautiful Sonosite export ultrasound machine that is incredibly expensive. And there was also another donor, and we all of a sudden had this amazing ultrasound machine in the emergency department. And then, when you talk about the kind of language of medicine and kind of referring patients on or discussing with a radiologist or a cardiologist or a trauma team in Edmonton, etc., you've already got a documented ultrasound in, just say, in the setting of trauma, which actually made a huge difference for your patient's care. And I'd say that I still love ultrasound. I use it a bit less because I'm not primarily stationed in the emergency department right now, but certainly use it quite frequently on the hospitalist ward. Have to go and borrow an ultrasound from one of the other departments. But getting involved, I'd say for you guys, is whenever you see someone using ultrasound, I can almost guarantee you that they will passionately tell you what they're doing. Look at how they orientate the probe, where they're placing it on the patient's body, how they troubleshoot to get the best possible image, what they're looking at, what normal is, what abnormal is, and then start doing the courses. Attend courses that are attached to conferences, and then eventually just do the CPOCUS, the courses, and do the exams and get qualified. It's brilliant, and just use it as much as you can.
Amazing. And yeah, we continuously hearing about how it's revolutionizing day-to-day hospital practice, and it's really inspiring to hear how you really empowered the rest of your team there to get everyone trained up. It's really cool to hear about. Two things. One was like I never really, I guess, thought so explicitly how much ultrasound also changes things from the patient. I really appreciated hearing you talk about that. We usually very kind of self-centered think about how it can help us help the patient make a better diagnosis, etc. But for a patient where a lot of the medicine can, I think, be in a black box, to actually show them an image of something can be so reassuring. I just wanted to share that reflection. That was really cool to hear about. And second, yeah, with the ultrasound, we had an episode recently on this podcast where I interviewed some people who had booths at the International Critical Care Conference over in Belgium, and one of them was a new ultrasound machine, which are getting progressively smaller and smaller and smaller. It's still kind of unaffordable, but I can almost imagine a really interesting future where these are just accessible to buy, and you kind of have it in your med school kit with your stethoscope and your little pen light, and then you also have your ultrasound probe that connects to your iPad. And with AI training integration, we'll be able to just train you. Do you have like a private tutor just built into the machine? So I think it's all extremely interesting. And I look forward to the day where the machines are kind of more accessible financially, so med students can kind of train themselves. But otherwise, it's great to have the CPOCUS and so on. Those are just some reflections that I wanted to share. But I think we're kind of getting near the end. I want to be respectful of your time, but I think before we go, we mentioned a couple of times, Delbert and I are heading into clerkship, third year medical school. We're kind of out of the classroom and into the field, so to speak. We'll be working full time on services, and it's going to be kind of trial by fire. I think a lot of students are quite nervous. You hear horror stories of your mentors just yelling at you or embarrassing you. Your whole identity of, being capable of being a doctor is going to be questioned. So I think just as somebody who has experience teaching medical students and being around medical students, we would love just to hear some general advice that you might have for us and medical students in general as we move on to this next step in their career. And how do you really succeed as you're a medical student working as a part of a team in a hospital where you don't really know what you're doing, but you want to do stuff and you want to learn. And any general advice you have in that regard, we'd appreciate it so much.
So much to say. I would say, first of all, be patient with yourself. You cannot be perfect, and you cannot know everything. And there will always be people who know more than you and who you perceive to be better. I'd say stay humble and be an absolute sponge of taking in as much information and experience as possible. And I'd say open yourself up to the opportunity to learn and to grow. And I'd say that there's so many important points here to mention. In the beginning, when you're a medical student, sometimes you'll see a style of students and residents and attendings spending a whole bunch of time dismissing what the patient doesn't have, but not focusing enough time on what they do have. So you'll hear, you're like, oh, it's the chest pain doesn't sound typical. It's, it's probably just MSK, or the headache. They've always had headaches. Sounds like a tension headache. I'd say be focused on exploring what the patient actually does have, and using every single opportunity to learn from the patients. Spend time speaking to people and really kind of bring out as much of your inner empathy as possible, and understand what is important in these people's lives, and how you have the opportunity, a very unique opportunity, to really shape your own experience and kind of destiny as a physician, but also the impact that you can have on this patient's life. They're gonna remember maybe 20% of what you tell them, and their expectation from you is that the medicine, the biological part of the care that you give them, is going to be done. You should know how to treat a pneumonia, so you'll treat the pneumonia. They don't. When they go home and they reflect, they're not going to remember, oh wow, that doctor, he noticed on my ECG that I had Wellen sign, and I was referred to the cath lab, and he's such a good diagnostician. They're going to remember the journey. They're going to remember how you made them feel. Their expectation is that you're going to deliver adequate or amazing medical care. What the expectation is kind of on the fence about is how they're going to be treated, and how you're going to communicate with them, how you're going to show up for them. They're going to remember as you were walking out and they said, oh, just one more thing, doctor. Do you mind spending 5 minutes? Would you mind just calling my daughter? She's an occupational therapist in the US, and she's the medical person in the family. Taking that time, and even as a student, understanding the importance of that. Showing up for your patients, understanding who the human is behind the number that's on your list of patients to see, understanding what they need from you, and how you have this amazing opportunity to actually shape or change their life. And as students, I'd say it's great to really try to respect your boundaries of I want to have a good work-life balance, etc. There is a very unique thing about medicine, and that is you have a responsibility to patients, and the way that you learn and the way that you experience things is by seeing patients, by speaking to them, by speaking to your colleagues, to your mentors, learning, reading, etc. But ultimately, that responsibility is going to fall upon you when you're in attending. So, really taking this opportunity to learn, if it means doing an extra call or spending an extra hour after the time that you were going to be there, but it's an amazing learning opportunity, I'd say be open to it, and really be open to the opportunity of learning, because it's endless. There's endless number of patients, there's endless number of hours. You'll never know everything, but I'd really encourage you and everyone else to do the things that you need to do to show up as the best possible version of yourself as a physician and as a human being, and kind of understanding the human being, and really delivering the best possible care as the best possible advocate, uplifting people around you, and using this unique opportunity to really shape someone else's life.
Wow, that was really inspiring, and I think it's very clear to me that any medical student would be extremely lucky to have you as a mentor. Any patient would be extremely lucky to have you as a doctor, and any staff would be extremely lucky to have you as a colleague. Dr. Chapman, it's really inspiring. Yeah, just really loved our conversation today. I'd like to end the way we end with all of our guests, which is just to ask you a series of rapid fire silly questions and keep you on your toes and see what comes out. You up for that?
Sounds good.
Okay, here we go. The organ that's responsible for the majority of the problems in the hospital is?
The kidneys.
Can a patient get white coat hypertension if the coat is black?
No.
No, definitely. Yeah, that's what I thought. Best place to hide in the hospital where no one would ever find you?
Some random stairwell. Sometimes you actually have lunch in those stairwells.
Yeah. All right. If you could only use one physical exam technique for the rest of your career, what would it be?
Can it involve ultrasound?
Let's say yes, because I think people are now saying that just ultrasound is just a part of the physical exam now. So we'll give you a pass with that one. Okay, here's a fun one. If your ex-wife was a doctor, what specialist would she be?
A neurosurgeon, because I probably would never have seen her.
All right. The best unknown food hack in the hospital is?
A snack bar in your white coat.
Oh, wonderful. Okay, and on the topic of food, I'll give you a little South African one to finish, and that would be beef jerky or biltong?
I mean, it's going to be biltong, but since that I'm vegan now, it's for the last 10 years, it's going to have to be vegan biltong, which is actually delicious, but definitely you can't compare biltong and anything else.
That's wonderful.
And any South African who says any different they should come and talk to me.
Well, yeah, that concludes. We just want to say thank you so much. Amazing to hear about your experiences, especially as medical students. Amazing to glean your kind of endless points of wisdom. And we hope to maybe see you on rounds someday or on rotations if we're lucky enough to get placed with you. Thank you so much for your time. And we wish you all the best with your patients and continued success in your career.
Thank you so much.
You guys too, and thank you so much for having me on. And yeah, good luck with the rest of medical school. And I cannot wait to see where you and your colleagues land up. It's going to be fantastic. Stay inspired.
All right, so that was our conversation with Dr. Larry Chapman. I sort of talked about this during our conversation, but it was such a refreshing perspective to hear him express such enthusiasm and optimism for healthcare as it is today. We know that there are often a lot of people with maybe negative outlooks in healthcare, whether that comes from people in the field or general public. But hearing Dr. Chapman talk about the most important thing, which is keeping the patient at the center of our of what we think about, and think of all these different ways to advocate for them, including ultrasound, or asking them, what do you think you came in with, or what brought you into hospital, really just emphasizes how important it is to have purpose, and the importance of having an unwavering commitment to your patients. And I think as medical trainees, at any stage of training, it's important to keep this perspective with us, as it grounds us, as Dr. Chapman has demonstrated, in very, very difficult and challenging circumstances, whether it is emergency high acuity settings, under-resourced settings, overstrained settings. And he described a lot of strategies by which we can try and mitigate some of these challenges, whether that's keeping ourselves grounded, of course, individually, working with members of our team, such as nurses and consultants. And then at the system level, pursuing QI projects, he spearheaded, of course, the adoption of ultrasound. And it was wonderful to hear his perspective on how ultrasound has transformed his practice and how important it's going to be for the rest of our careers as well. Sas, do you have any reflections you want to add?
Yeah, I also, like you, really enjoy the conversation. There's a lot of food for thought that I'm going to be thinking about, over the next days and weeks to come. And we just so appreciated his time. I think what's sticking with me right after we had our conversation is just the importance of the human approach and how Dr. Chapman emphasized the human approach, not just with patients, but also with staff and with colleagues and everyone who works in the hospital. It can really, really take you very far. And I hope all the listeners got as much out of the conversation as we did, and that was absolutely great. I look forward to seeing you on the next episode, Delbert. Maybe we'll just do a solo episode. And with that, I'll sign us off. So that was Two Guys in Scrubs. If you want to support the podcast, leave us a like or review wherever you listen to your podcasts. We should be there. Thanks for listening, and we'll see you next time. Give us a little jingle.
Jingle, jingle, jingle. Jingle, jingle, jingle.
Jingle, 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 jingle. See you next time.